Welcome everyone to the Canadian Diabetes Association's 2016 webinar series. My name is Farah Ismail and I'm a program manager for the CDA, and I will be your host this evening. We are delighted that you're able to join us today for our webinar to learn about diabetes, sexual health, and you. Now, to start off, I would like to draw your attention to our survey. It's located at the top right-hand section of your screen. In order for CDA to better serve your needs, we kindly ask that you provide us with your input by completing the survey towards the end of the presentation, and we thank you in advance for your input. Throughout the presentation, you will have the opportunity to ask questions, and this can be done by simply typing in the question and answer box, which is located towards the bottom right-hand section of your screen, and our presenter will be happy to answer your questions at the end of the presentation. As well, we will be displaying a few polling questions throughout the presentation and would love for your participation. Please note that these questions will remain completely anonymous. Also note that you are able to customize your screens. This can be done by simply dragging down the bottom right-hand corner of each of the webinar pods to either expand or collapse each of the screens that you see. Our presentation today will last about 40 to 45 minutes in length, and we'll have about 10 to 15 minutes left at the end for questions. We will be posting this webinar on our website at a later date should you wish to participate in it or review it again. So now I'd like to welcome our speaker, Dr. Adam Millar, and thank him for joining us today. But before turning it over to Dr. Millar, I'd like to give you a brief introduction. Dr. Adam Millar is an assistant professor and clinician teacher in the Division of Endocrinology and Metabolism at Mount Sinai Hospital. Dr. Millar is a general endocrinologist with clinical expertise in andrology and is the only endocrinologist in the University of Toronto system with this focus. A wide range of andrologic conditions are managed in Dr. Millar's andrology clinics, including male hypogonadism, infertility, sexual dysfunction, disorders of sexual development, and gynecomastia. For more information on Dr. Millar, please read the speaker bio section, and that's located on the left-hand section of your screen. So without further ado, I present to you Dr. Adam Millar.
Thank you everyone for attending our webinar tonight. My name is Adam Millar, and I'm here to speak to you today about sexual dysfunction and diabetes. Start off with our objectives for this evening. They are, as you see here, to outline the types of male and female sexual dysfunction seen in people with diabetes, to understand how diabetes can contribute to sexual dysfunction, to understand what questions, examinations, and tests may be conducted during a sexual health exam, and to describe the treatment options available for people with sexual dysfunction. This is how I hope to achieve those objectives, starting off with a description of the role of diabetes in sexual dysfunction. Then we'll move on to focus specifically on male sexual dysfunction, starting off with a description of erectile dysfunction, its causes and treatment options. We'll touch on testosterone therapy, what its indications are. We'll then discuss low libido or reduced sex drive, and move on to ejaculatory dysfunction. From there, we'll close off today's webinar on female sexual dysfunction. We like to start off by getting a sense as to who's participating in our webinars. So I would like to ask everyone, how are you affected by diabetes? Do you have type 1 or type 2 diabetes? Are you at risk of diabetes? Are you a caregiver? Or are you a healthcare professional? I'll give you a few seconds to gather your thoughts and submit your answers. Okay, so this is interesting. We did an earlier webinar today, and that was majority healthcare professionals, whereas I see here we have majority of people with diabetes, mostly type 2, but a good representation of people with type 1 as well. Excellent. So we'll start by talking about the role of diabetes in men. We know from studies that men who have diabetes are 3 times more likely to develop erectile dysfunction than men who don't have diabetes. We also find that they tend to develop erectile dysfunction about 10 years earlier than their peers. Several things can affect the severity of erectile dysfunction. This includes increased age, increased duration of diabetes, having poor blood sugar control, and the presence of microvascular complications, so issues affecting one's eyes, kidneys, or nerve sensation. What about the role of diabetes in women? We know that female sexual dysfunction is much more common in women with diabetes. Furthermore, it can affect multiple aspects of the sexual response cycle, including arousal, excitement, satisfaction, lubrication, and the ability to achieve orgasm. Women with diabetes also can complain of pain during intercourse due to vaginal dryness. Another important thing that we can't forget is that sexual dysfunction impacts the quality of life of both men and women. Studies have shown that people who have sexual dysfunction have lower confidence, have lower self-esteem, and tend to display a lot of symptoms associated with depression. This is a component of sexual dysfunction that we can't forget about. One of the main messages I want you to get from our webinar tonight is that communication really is key when talking about sexual dysfunction, both in initiating investigations and subsequent treatment. We know from studies that many people are reluctant to discuss sexual health with their physicians. In fact, we have studies showing that over 70% of people felt that it would be embarrassing to discuss sexual problems with their doctor. The interesting thing to note, however, is that 80% of patients with erectile dysfunction would welcome discussion. In fact, most would prefer that their doctor broach the subject. The problem we have is that doctors don't do a very good job about asking their patients about sexual health. One study that looked at family physicians found that only 15.5% of them asked their patients about sexual dysfunction. There's a lot of barriers that exist in regards to communication. We know that a lot of medical practices are very busy and there's not a lot of time in a medical appointment. This can lead to a lack of opportunity to raise these issues in the first place. Many people have a sense of embarrassment or shame about speaking about sexual dysfunction, and indeed there's a societal taboo about discussing these issues openly. Some people may have pessimism about the outcome of a discussion. They may think to themselves, what's the point of bringing up something? I don't think there would be any viable therapy for it. Some people are uncertain if sexual problems are even within the realm of physician-led care. Or people may wonder what specialty treats their sexual issues. Should they be speaking to their family physician, their endocrinologist, or should it be a urologist or a gynecologist? All these factors lead to people withholding information or not disclosing information about their sexual health overall. So at the risk of sounding cliche, it really is vital that you talk to your doctor if you have any sexual dysfunction or think you may be developing some of the symptoms that we'll discuss later. If we don't talk about this, then we'll never initiate those investigations and we can never start a treatment course. We're going to shift our focus to male sexual dysfunction, starting off specifically with erectile dysfunction. Presently is defined as the inability to achieve and maintain an erection sufficient for satisfactory sexual function. Some of you may be more familiar with the term impotence. However, that's fallen out of favor over the last few years. I'm going to get everyone involved in another audience question. Which of the following features is a risk factor for erectile dysfunction? Is it age, diabetes, high blood pressure, high cholesterol, or all of the above? I'll give you a few seconds to submit your answers. Excellent. So 97.3% think that all of the above are risk factors. This is true. All of the above not only are risk factors for erectile dysfunction, but also risk factors for vascular or blood vessel health in general. When we talk about erectile dysfunction, a very important feature of this is getting adequate blood flow to the penis and keeping that blood within the penis to sustain that erection. So good job, everyone. Let's Let's talk a little bit more about the causes. So we mentioned that decreased blood flow can be a cause of erectile dysfunction, but nerve damage can as well. You need that nerve sensation to be able to produce an adequate erection. Both nerve damage and decreased blood flow can be related to diabetes, and specifically are linked to chronically elevated blood sugars. But it's important to realize that it's not just blood sugar that manages erectile function. There's other features at play. Many individuals with diabetes use medications such as blood pressure pills, which can affect blood flow, and antidepressant pills, especially the class of drugs called SSRIs, which are well known to cause various forms of sexual dysfunction. There's also many psychologic features that contribute. Individuals who have depression or anxiety are known to have issues with erectile function. There's also situational issues that can contribute. Some men may have concerns about anticipatory anxiety, which can lead to erectile dysfunction. Other men may have relationship issues that are preventing adequate erectile function. I even have some men in my clinics who have developed erectile dysfunction after the stress of trying to achieve fertility with their partner. When you speak to your physician about erectile dysfunction, you should realize that they'll likely ask you a few important questions and perform a focused physical exam. In fact, most of the important information about sexual dysfunction is obtained from these two features. Some of the questions you could be asked is, what is the primary concern? And this is important because it may not just be erectile dysfunction. It could be low libido, it could be ejaculatory dysfunction, it could be other features of the sexual response cycle. It's important to understand when the dysfunction started. Was it sudden onset or did it come on gradually? This can help your physician try to determine what the underlying cause could be. It's important to know if anything makes it better or worse. For example, is it better with a specific partner? Is it worse when you're taking certain medications? Another thing to know is whether there's been any changes to your health. Have there been any new medications like antidepressants, blood pressure pills, or opiate-based pain medications, for example? Are there any new relationship issues? Are there any new stresses in your life, such as loss of a loved one, stress at the job, or otherwise? Physical exam usually will start as a general exam looking at features like blood pressure, pulses, heart rate, heart sounds, and then we'll usually focus more on features such as the penis, looking for any structural abnormalities, and the testes in regards to size and any textural changes. Doctor may also want to do some blood tests as well. Most commonly what's checked are blood sugar levels and cholesterol levels. Both of these aspects can affect vascular health and blood flow, which, as we learned before, contributes to erections. You may notice that there are some men's clinics around, and they may offer extra testing like ultrasounds, blood vessel studies, or response to injection therapies. Many of these are often at cost to the patient. And to be honest, they're rarely necessary. Often with a good history, physical exam, and a few baseline blood tests, that's usually enough for us to start on a trial of therapy without needing any of these other expensive and often unnecessary tests. Another test that may be done by your physician is an early morning testosterone level. I put down ×2 because it's important that we have low levels on more than one occasion to confirm that it is indeed low. As per the CDA 2013 clinical practice guidelines, it's advised that men who have both diabetes and erectile dysfunction should have their early morning testosterone levels checked, given that levels are often low in these men. So one could consider a trial of testosterone therapy if they meet the following criteria. If they have 2 low early morning testosterone levels, if they have symptoms that we'll discuss in a few slides, and if they have no other medical issues that would prevent the safe use of testosterone therapy. So talking about those signs and symptoms of low testosterone, this is a slide that shows you many of them, and I can appreciate this is a very busy slide, but I'll try to navigate us through this. There are non-sexual symptoms linked to low testosterone, such as low energy and vitality, diminished physical performance, decreased mood, impaired cognition or ability to think, and in some men, increased fatigue. Some men may note hot flushes or sweats, poor concentration and memory as well. There's also physical signs that one can see in some men with low testosterone, including increased waist circumference, decreased testicular size, reduced body hair, and male breast growth or gynecomastia. Some lab findings as well include anemia or low red blood cell count, reduced bone mineral density, and obesity. There's also sexual symptoms that you can see here circled in red. These include low sexual desire or libido, difficulty with orgasm, lack of spontaneous erections, decreased intensity of orgasm or absence of orgasm, and decreased sensitivity of the genitals. Now, there's a lot of signs and a lot of symptoms listed on this page, and an important point I want to make here is that many of the signs and symptoms you see here are not specific. So just because someone may have 1, 2, or 3 symptoms on this page doesn't necessarily mean you have low testosterone. As you could imagine, there's a lot of other medical conditions that can contribute to some of these signs and symptoms. Many of these symptoms can be seen with hypothyroidism or depression, or can be the side effect of medications. So it's important that you consider other contributing medical factors as well, and of course confirm with the low testosterone value before considering testosterone therapy. If it is deemed appropriate to proceed with testosterone therapy, then there are several options available in Canada today. Most commonly, we see patients being prescribed injections, gels that are applied to the skin, patches that go on the skin, or capsules that are ingested. We work through these one at a time. Injections are typically given by a family physician or a nurse every 1 to 2 weeks, depending on the dose. Gels that go on the skin are usually applied at home by the patient themselves. Skin patches likewise are applied by the patient every few days. The oral capsules are taken several times per day. In regards to potential benefits, really one could expect to potentially see benefits in any of the features we showed on the previous slide. The important point here is that it may help some of these symptoms. I see some men who have improvement in multiple signs and symptoms that are noted on this slide. But conversely, I also have men who've tried testosterone and don't notice any improvement at all. So testosterone is a hormone, but it's important to remember that it's still a drug. And like any drug, it has the potential for side effects. Some of the risks associated with testosterone therapy are what you see here: a decrease in testicular size and a decrease in sperm count. So it's important that men who are trying for fertility don't take testosterone, as it typically will reduce one's chances at fertility. Testosterone can cause an increase in the red blood cell number, and this could theoretically make the blood thicker and potentially predispose to clotting as well. We know that the prostate grows after testosterone is administered, but we don't believe at present that it causes prostate cancer to grow anew. We know that there are studies that show in men with metastatic prostate cancer that testosterone therapy can cause that to grow, but there are some men with prostate cancer who have been treated with testosterone therapy who haven't had any growth at all. So this really remains an area of controversy right now until we have larger studies that can confirm for us where the risk lies. Equally controversial is the issue of testosterone in the heart. There are some studies that have suggested that older men and men who have pre-existing heart disease may be more at risk of heart events or death after using testosterone. But then subsequent studies have suggested no harm. And again, until there really is a large, adequately designed study that puts this question to rest, I think this will remain a controversial topic. We're going to go back to another audience poll. Which of the following erectile dysfunction pills is the most effective? Your options are Viagra, Cialis, Vitra, or all are equally effective. I'll give you a few seconds to decide. Great. So 92% said that they're all equally effective. And I would agree with you there. I'll show you some of the data that we have here. When we talk about erectile dysfunction treatment options, first-line therapy are those pills, the pills that we call PDE5 inhibitors. That's your Viagra, your Cialis, your Levitra. So amongst those three types, they all work equally well. Head-to-head studies really don't suggest that one of these pills is better than the other. Now, we sometimes find that some of our patients will respond better to one pill than the next. We don't have a good way of predicting who will respond best to what pill, so we usually just go through trial and error to find out which one works best. All three of the pills are taken on demand, and there's a form of Cialis that can be taken daily. That one allows for better spontaneity, and in some men also helps decrease some urinary symptoms. Most common side effects with these drugs include headache and flushing, and most severe side effects associated with these drugs is priapism, in which someone develops an erection that lasts longer than 3 hours. This is considered a medical emergency. The likelihood of it with these drugs is rare, but people still need to be made aware of this potential effect. The thing we find with these pills, however, is they don't work as well in men with poorly controlled blood sugars as they do in men with well-controlled blood sugars or no diabetes whatsoever. And here's a picture just showing you the shape and the color of Levitra, Viagra, and Cialis for those of you who know the appearance of the pills rather than the name. I'm going to speak a bit about drug failure with these PDE5 inhibitors. I put failure in quotes because we often find that there's a few steps someone can take before we really deem it to be a failure. We want to make sure that the drugs are taken at least 1 hour prior to the planned event to allow time for absorption. We want to make sure that the individual has had sexual stimulation, whether that be psychological stimulation, physical sensation, whatever. One can't just expect to pop a pill and get an instant erection. It's also better to avoid alcohol or large meals, especially if you're taking Viagra. These factors tend to affect the absorption of that drug in particular. We advise patients not to use more than one pill in 24 hours, as it could increase one's risk of priapism. We also tell people to try these pills a few times before claiming failure. Typically, we say try the pill at least 4 times before you decide whether or not this is useful for you. In the last session, someone asked me if those 4 pills have to be tried in 4 subsequent days, and I said no, you don't necessarily need to have it back to back to back to back. In fact, I'd be impressed if you could have it back to back to back to back anyways. But I digress. Which of the following drugs cannot be used at the same time as erectile dysfunction pills, or PDE5 inhibitors? Is it blood pressure pills, cholesterol pills, nitro patches, metformin, or insulin? I'll give you a few seconds to collect your thoughts and let you submit your answers. Great. So we have a few people saying blood pressure pills, and we have a high percentage saying nitro patches. Excellent. I'm going to show you something to reinforce this fact.
What do we got?
Cardiac arrest. Sinus check 120.
BP?
158 over 95. 41, right here.
Perfect.
All right. Careful.
We've already got a line in. Let's switch over to monitors.
How are we doing? Doc, he's had 30 minutes of chest pains, nausea, shortness of breath, pulse 104, respirations 18.
Let's get the CBC, CMP, cardiac penile at 1280 kg.
Yes, doctor.
Mr. Sanborn, I'm Dr. Mercer. Are you in any pain right now?
I feel some pressure in my chest. It's real tight.
Can you show me where the pain is?
Right here.
Really good.
What were you doing when the pain started?
I was kissing a beautiful woman.
Were you having intercourse?
Unfortunately, no.
Sense of humor intact?
Yeah.
Give him an aspirin, metoprolol, 5 milligrams, and hang a nitro drip. Mr. Sanborn, your EKG shows you have a blocked artery which is not allowing enough oxygen to get to the heart muscle.
I'm having a heart attack.
We're gonna stop it, but I need to know what medications you take.
I take libido.
To this.
Anything else?
Why for blood pressure?
And what about Viagra? Mr. Sanborn, did you take any Viagra today? Mr. Sanborn?
No. No Viagra.
Okay, good. Just needed to be sure because I put nitroglycerin into your drip. And if you had taken Viagra, the combination could be fatal.
Okay, so Jack illustrated a very important interaction here. It's important that individuals who are on PDE5 inhibitors disclose to physicians in emergency situations, and in fact any situation where drugs are involved, if they're going to be considered for nitrate-containing medications, whether that be a nitro drip or a nitro patch. Likewise, if you're talking to your physician about sexual dysfunction and there's consideration of starting a PDE5 inhibitor, you absolutely should let them know if you're already on a nitrate-containing medication like a patch or taking the spray. We're going to progress now from the pills on to penile injection therapy. As you can see here, this involves use of a syringe that contains 1, 2, or 3 substances that encourage blood vessel opening within the penis, allowing increased blood flow and improved erections. As you can imagine, this has a high rate of discontinuation due to the side effects related to this, which could include pain, bleeding, or scarring if you repeatedly inject along the same tract. There is a higher risk of priapism with this drug, and as such we have people trained to start at a low dose and gradually titrate up to effect. Another issue is lack of spontaneity. Obviously, it's harder for men to hide a syringe than a pill from their partner. Another option is the penile vacuum pump. This involves putting a pump over the penis, which then creates a vacuum. This draws blood into the penis, creating an erection. Then one places a constrictor band around the base of the penis, which encourages blood flow to remain within the penis itself. Now, this tends to have lower patient satisfaction than some of the other treatment options. People note that over time the erection feels cool to touch because you're not having active blood flow continuing. Well, there's a lack of spontaneity, and we see as a result of that a high rate of patient discontinuation. The most invasive option is penile implant surgery. This is typically reserved for people who have failed the prior therapies that we outlined. It has a very high satisfaction rate, 93% satisfaction, compared to 45% for the pills. There's a bit of selection bias in this survey, but still, most patients who I've spoken to are quite pleased with the effect. Well, many men note that it has a greater than 10-year functional life, so it's quite a long-lasting effect. The important thing to note is that sexual dysfunction in men is not just limited to erectile dysfunction. It can include things like libido or reduced sexual desire, premature ejaculation, which is ejaculation that occurs less than 1 minute after initiating intercourse, retrograde ejaculation, which is when one ejaculates backwards into the bladder instead of out of the penis, anejaculation, which is inability to ejaculate, and delayed or absent orgasm, otherwise known as anorgasmia. I'm going to shift gears to low libido or reduced sex drive right now. Many causes of this in men. We know that there's hormonal contributors such as low testosterone or high prolactin, another type of hormone. Medical conditions like underlying diabetes. Medications, again antidepressants, can play a role in decreased sex drive. Psychologic factors like relationship issues or psychiatric illness. Then there's a term called hypoactive sexual desire disorder. It's basically a grab bag term, short for we don't know the underlying cause. Now I'll talk about the role of diabetes in regards to low libido. There's several aspects that connect diabetes with low libido. One could have nerve damage from chronically elevated blood sugar. This can cause reduced sexual sensation, which can lead to decreased sexual desire because of lack of pleasure. Individuals with erectile dysfunction, as you remember, can also have depression and self-doubt. This can also impact one's libido. In regards to treatment, there are no medications, unfortunately, that specifically target low libido. If someone has low testosterone, you could potentially take testosterone replacement. If someone has high prolactin, you could theoretically take a medication that lowers that for you. But otherwise, there's no magic bullet for low libido. You should also treat any underlying medical conditions that may be thought to contribute. An example of this would be treatment of depression or pain. Also, one should consider changing possible culprit medications. Again, antidepressants can contribute, some less than others. We also could consider psychological relationship counseling if it's thought that relationship issues could be playing a role. Talk for a bit about ejaculatory dysfunction now. Prevalence of this issue is broad. It depends on which study you read, but estimates state anywhere between 1/3 to 2/3 of men with diabetes can have some type of dysfunction in regards to ejaculation. It can include premature ejaculation, delayed ejaculation, retrograde ejaculation, or anejaculation. Men who have ejaculatory dysfunction find that it's often related to nerve dysfunction due to chronically elevated blood sugar. If the nerves aren't working well, you may have difficulty opening and closing the sphincter muscle at the neck of the bladder. If you're not able to close the sphincter muscle completely, then you can get ejaculation going backwards into the bladder instead of out of the penis. There are medication treatments for premature ejaculation and retrograde ejaculation. Some men with premature ejaculation, there are numbing creams. They can use condoms to reduce sensation, and potentially also off-label use of PRN antidepressants. Retrograde ejaculation in some men can be treated with Sudafed as long as their blood pressure is under good control at baseline. Fortunately, delayed ejaculation and anejaculation are usually not reversible. In some cases, they may be related to low testosterone, so that's worthwhile looking into. If someone has ejaculatory dysfunction and they desire fertility, they may need to speak to a specialist to see if there's any way to obtain semen through other means. I'm going to shift now to female sexual dysfunction. It's an important topic that isn't often addressed. And believe it or not, there's actually not a lot in the medical literature that addresses this issue in women with diabetes. Our next question is, which of the following is a cause of female sexual dysfunction? High blood pressure, relationship issues, recurrent urinary tract infections, medications, and I'm going to add a fifth category, all of the above. Whichever one you prefer. So, for some reason with tonight's webinar, we're missing the option for all of the above. It was there at our 2 o'clock session, but I guess we have a bit of a technical glitch here. But the correct answer would be all of the above. High blood pressure, relationship issues, recurrent UTIs or urinary tract infections, and medications, they all, in theory, can contribute to sexual dysfunction. One study that looked at 72 women with type 2 diabetes found that there is an incredibly high incidence of sexual dysfunction amongst women with diabetes. 72% in that study noted low libido, with 2/3 of them noting decreased clitoral sensation. Over 1/3 of women noted vaginal dryness, with slightly more noting painful intercourse. Almost half of respondents also reported reduced orgasm. But it's not just the physical aspects. Another study of women with diabetes noted that the participants tended to view themselves as less sexually attractive, and in general were not satisfied with their sexual life. So the psychological component is tremendous. I guess one of the questions is, why do women tend to get sexual dysfunction in relation to their diabetes? Many women with diabetes and those who have chronically elevated blood sugars can notice more frequent urinary tract infections and potentially more vaginal yeast infections as well. This can affect sexual health. It obviously could affect one's libido and could also lead to dryness, itchiness, or pain. Nerve damage related to high blood sugar can also affect vaginal sensation. If one's not able to sense sexual stimulation, then they may have decreased response, decreased vaginal lubrication, which can lead to decreased pleasure, decreased orgasm, and potentially also to pain involved with intercourse. Studies have also consistently shown that sexual dysfunction in women appears to be related to their duration of diabetes. The longer one has diabetes, the more likely she is to have sexual dysfunction. Now, when women with diabetes talk with their physicians about sexual dysfunction, they'll be asked many of the same questions: what their primary sexual concern is, when it started, does anything make it better or worse, any changes to your health or new medications, are there any new relationship issues or other stresses in your life? Physical exam will be similar in regards to assessing the heart, the blood pressure, heart rate, but may also include a pelvic exam and potentially a pap test as well. There are treatment options available. For women who have nerve damage affecting vaginal sensation and lubrication, one may find that stimulation of the clitoris may be helpful. Clitoris has a high density of nerve endings, and so individuals who have decreased sensation in the vagina may still have intact sensation in the clitoris. Those who have vaginal dryness and painful intercourse, they may find that water-based lubricants may be helpful. Medication changes may also be useful. So someone who has low libido, if it's due to an SSRI antidepressant, you may want to speak with your physician about other alternate options if it's deemed to be an appropriate substitution. General tips for treating sexual dysfunction for both men and women with diabetes. You want to optimize risk factors, and again, a lot of these risk factors affect blood flow. Those being blood sugar, blood pressure, cholesterol, and reducing or quitting smoking altogether. Can't forget the psychosexual contributors as well. We could consider psychosexual therapy or relationship therapy, or if those are thought to be contributing factors. So in summary, erectile dysfunction is very common in men with diabetes. However, it's not the only form of sexual dysfunction that men are affected by. Ejaculatory dysfunction and libido disorders are also very common. Men who have diabetes and erectile dysfunction should consider having their early morning testosterone levels checked to see if they potentially would be candidates for replacement therapy. Another important thing is that sexual dysfunction is also very common in women with diabetes. Unfortunately, is understudied and not often discussed. It's important to know that there are many effective treatments for sexual dysfunction in people with diabetes. But you won't get any investigations carried out or treatments if you don't communicate about those problems. Communication with your doctor is the first step in receiving these treatments, and both patients and doctors need to make a better effort at ensuring the lines of communication are open. So I've provided some resources here if anyone wants to read up a bit more on these topics. The Canadian Diabetes Association has their website that goes through some aspects of men's sexual health. Joslin Diabetes Center out of Harvard also has a chapter on sexual dysfunction causes and symptoms. There's a book put out by the American Diabetes Association entitled Sex and Diabetes, for him and for her. At this moment in time, I'd like to thank everyone for attending our webinar tonight. Thank you for participating in our polls. And at this moment in time, if you have any questions, I'd be happy to answer them now. Thank you.
Great. Thank you so much, Dr. Millar. You shared with us some really, really important information about diabetes and sexual health. And as you've already mentioned to earlier, it's definitely a topic that people have a bit of a hard time discussing. So having it, the information available through a webinar today, it's been a very great success. With that being said, we'll start with our first question here from one of our participants. And just to let everybody know, if we do not get to your questions, please email us at webinars@diabetes.ca, and we'll be sure to provide you with a response. Our first question here, one of our participants has asked, is male incontinence a complication of diabetes, and is this a reason for concern?
Thank you. So yes, male incontinence absolutely can be linked to diabetes. Certainly, I just saw a gentleman the other week, and his primary complaint was incontinence, and that's how he was diagnosed with diabetes. He was urinating too much during the day, and a few times during the night also had a few accidents as well. So high blood sugars can lead to increased urination. Not only acutely, but also when we look at things chronically, anything that leads to nerve dysfunction like chronically elevated blood sugars can affect how the bladder contracts, how the sphincters open and close, and thus can affect urine flow. Definitely is an important issue, and this is something that should be discussed with your family physician initially to see if there's any obvious secondary causes that can be ruled out. If nothing is found that can obviously be managed right away, then you may be referred to a urologist who can engage in some urodynamic studies to try to elicit the underlying cause. Great question. Thank you.
Great. Thank you for that response. Our next participant has asked, have you seen any relation between men with a vasectomy and ejaculatory dysfunction?
Okay. It's a good question. I don't see a lot of men who follow up for ejaculatory dysfunction following vasectomy. I know many of my colleagues in urology certainly engage in vasectomies, both the procedure themselves and vasectomy reversals. I can tell you that in my clinical experience, I haven't seen a lot of patients with ejaculatory dysfunction following vasectomy. I think theoretically it would make sense that this could be a potential complication. If this is a concern, I would go back to the surgeon who originally performed the surgery to see if there's any possibility that it could be related. And if not, then you're always open to a second opinion from one of our experts. For example, if you're in the Toronto area, we have many experts at Mount Sinai Hospital who can address that question in more detail for you.
Great. Thank you for that response. The next question here, I'm not too sure if you have the answer for it, but I thought I'd ask it anyway. To your knowledge, are you aware if erectile dysfunction surgery is covered by OHIP?
Okay. Good question. I forgot to mention that this time. I think I mentioned it at the prior webinar today. So presently, it is at cost to the patient. OHIP's not regularly covering this procedure. Now, the ballpark figure that I've heard is that this costs around $5,000. That depends on the surgeon fees, the hospital fees, and so on. But as far as I know right now, I don't believe OHIP would cover that, unfortunately.
Okay, great. Thank you for that clarification. Our next participant has asked, do you recommend any natural herbal supplements to assist with increasing libido?
Thank you. So there are a lot of supplements that have been touted as potentially benefiting one's libido. I can say that looking through the studies that I'm aware of, none of them have been conclusively shown to consistently raise libido. So we're unfortunately stuck with this situation where if someone doesn't have an obvious reversible cause, there are no medications, whether they be pharmaceutical or herbal, that conclusively impact one's libido.
Okay, great. Thank you for that.
I'm going to mention as well, sorry to interrupt there, some of the supplements that are out there, you sometimes may see things at health stores or over the counter. One of the problems we sometimes may run into is we don't always know all the substances that can be in these supplements, especially if you're buying them from a less reputable source. Theoretically, some of these supplements could be tainted with other drugs as well. So we usually advise against using any substance of which you're not familiar of all the constituents within it.
Okay, great. Thank you for that response. Our next participant has asked, does Viagra contain testosterone?
No, Viagra only contains a PDE5 inhibitor. So it contains a substance that acts on enzymes in smooth muscle cells. It affects the way that calcium is handled by these muscle cells and leads to relaxation of these muscles in the blood vessels, which leads to an increase in blood flow to the penis. No testosterone is contained within Viagra itself.
Great. Thank you for that clarification. Our next participant has asked, how important is neuropathy in the role of ED?
Neuropathy is it's very important. When we look at the causes of erectile dysfunction in men, we usually break them down into substances or drugs, things that affect blood flow, such as those vascular risk factors, endocrine issues like hormone disorders, psychologic contributors, and then the last category we often talk about are neurologic contributors or nerve damage. Certainly in men with diabetes, especially if they've had it for a long term, we see that erectile dysfunction can be quite profound if they already have severe underlying neuropathy. So great question. It's absolutely very, very important in the creation of erectile dysfunction.
Great. Thank you for that response. Our next participant has asked, is it better for a woman, to speak to their family doctor or endocrinologist about their sexual health relating to type 1 diabetes?
Thank you. So I would suggest initially speaking to your family physician if you're comfortable speaking to them about that issue. The reason why I say that is because family physicians will initially start with a holistic approach. Think about all factors that could be contributing, but also family physicians tend to engage in more pelvic examinations and Pap tests as well. Some endocrinologists may do this, but not all. So I think it's fair to start with your family physician. I think if you have an endocrinologist who has expertise in women's health, then you certainly could discuss that with them as well.
Great. Thank you for that response. Our next participant has asked, if someone has high blood sugar, can this cause them problems to get and keep an erection in comparison to if they had normal blood sugar levels that day?
Good question. You know, I've seen people who initially present with very high blood sugars at the beginning stages of their diabetes, and they will have erectile issues. Once we're able to get their blood sugar under better control, many of them, especially the younger ones, often note that they do get some of that erectile function back. Now, whether someone is going to note day-to-day variation, I don't get as much of a report from my patients about that. I think in theory it could be possible, but I can't say that's a consistent concern I hear from my patients.
Great, thank you for that response. Our next participant has asked, if I get morning erections, does that mean my testosterone levels are okay?
Great question. Thank you for that. A lot of people seem to put a lot of weight into morning erections, nocturnal erections, spontaneous erections. To be honest, when we look at all those signs and symptoms related to low testosterone, a lot of them aren't specific, and a lot of them, truthfully, aren't sensitive either. And so if you had morning erections, but you still had low libido, you had erectile dysfunction throughout the rest of the day, you had decreased muscle bulk, fatigue, you still in theory could have low testosterone. I think if you have other symptoms that could be associated with low testosterone, then you should speak to your physician about testing for low testosterone and find out if indeed that is an issue for you.
Great, thank you for that response. A couple of our participants have actually asked this question here. Is there any diabetes medication that can cause sexual dysfunction or side effects that lead to this dysfunction?
Diabetes medications, right. So a lot of the culprit ones are often medications that are managing the risk factors associated with diabetes. So the primary one that I think of are some of the blood pressure pills. We know that beta blockers certainly can contribute to erectile dysfunction. Some of the water pills can as well. We see that ACE inhibitors don't tend to cause as much sexual dysfunction as some of the other blood pressure pills do. But really, we shouldn't see sexual dysfunction secondary to statins. We shouldn't see it secondary to insulin. We shouldn't see it due to metformin. Now, if someone were to get a complication like severe hypoglycemia, certainly that could impact sexual function, but I'm sure that a lot of people wouldn't necessarily be thinking about sexual function when going through a hypoglycemic episode anyways.
Great. Thank you so much for that response. Folks, we'll just take another question here before we close off for the evening. But if we don't get to your questions again, please email us at webinars@diabetes.ca, and we'll be sure to get back to you. Our final participant here has asked, what type of doctor should one go to if they're looking to get an erectile dysfunction surgery?
Right. So I assume the question is getting a penile implant. Certainly there's other surgeries related to erectile dysfunction if someone has a deformity of the penis, for example. To be truthful, it really doesn't matter what specifically the question's addressing per se, because really any dysfunction related to erectile dysfunction surgery should be referred to a urologist. They're the ones who have expertise in treating conditions like Peyronie's disease, which can lead to abnormal curvatures of the penis. They're also the ones who will do the penile implant surgery. It's always a good idea to read up a bit more on the urologist that you may want to see, since not all urologists have expertise in the area. It's a very specific and complicated procedure, so you want to see someone who has a lot of experience in that field or going under the knife.
Great, thank you so much. And folks, that does conclude our webinar for today. I'd sincerely like to thank Dr. Adam Millar for speaking on behalf of the Canadian Diabetes Association. It has been an absolutely great learning experience. I do want to remind everyone, so for any other additional questions we didn't get to, please email us at webinars@diabetes.ca. And I do also want to remind you that we are recording today's session and we will have it up available on our diabetes.ca website in the upcoming weeks. Just so you know, today is our last day for the first series for 2016, but we will be starting our Series 2 running from May to June over 5 weeks, and our focus will be specific to type 1 diabetes. So again, to view any past webinars, visit our website at diabetes.ca/webinars. And today's webinar, along with all the others from this year as well as the 2015 year, will be posted there. For those of you that are living with diabetes and are close to our Winnipeg region, be sure to check out our Winnipeg Expo that's happening on April the 23rd. So if you'd like some more information on that, please call us at 1-800-BANTING or visit our website at diabetes.ca/expo. For any other questions that you have with relation to diabetes, please call us at our 1-800 number line. So that's 1-800-BANTING, 1-800-226-8464. Thank you for participating with us today, and we look forward to your participation in our series in May.